Board. All right, thank you, everybody. Thanks, everyone, for joining this media briefing. It's from UNC Health. After the briefing, we will post an unedited video recording on YouTube, so you can download that and use it for your editing purposes. And we'll also make an unedited audio file available for folks in radio and just as a note-taking source. We have a number of folks that use it for that as well. Today's subject is basically, are emergency departments and doctors' offices safe? And our physicians on the front lines will give you their expertise on this. And also, equally important, why it's important to keep up with your scheduled health appointments during the COVID pandemic. You can't just postpone going to the doctor because of the situation. So at this point, I will turn it over to my UNC Health colleague, Alan Wolf, and he will introduce today's guest speakers. Alan?
Thanks, Phil. Thanks for joining us, everyone. Our expert guests today are Dr. Ryan Lamb, Medical Director of Emergency Medicine at UNC Rex Hospital in Raleigh, and Dr. Abhi Mehrotra, Medical Director of UNC Hospital's Hillsborough campus, and UNC Department of Emergency Medicine in Chapel Hill. Thank you both for taking the time to talk to the media today. Dr. Mehrotra, would you like to start off with a few opening remarks?
Sure. Good morning. Sorry, having a little bit of technical difficulty with the audio. Can you hear me okay?
Yes, sir.
Great. Good morning, and thank you for the introduction. My name is Abhi Mehrotra in the Department of Emergency Medicine at UNC.
This place on CDC, there you can subscribe to their news.
Yeah, somebody doesn't need to be on. Yeah, go ahead, doctor.
All right. Responsible for clinical operations at both the medical center and our Hillsborough site, and then also have a role with our system ED group, with our collaborative and helping lead that effort. So just a few opening remarks, and then I'll turn it over to Dr. Lamb. So first of all, I'd like to say thank you to our team. This has truly been a team effort in changing our processes kind of throughout everything that we've done in how patients arrive, how we care for them in the emergency department, and then when they leave the emergency department, either to be admitted to the hospital or to go home. Steps that we've taken and processes that have changed for safety purposes is, and I'll start from the very beginning in that kind of process and how patients arrive, how they're evaluated and treated in the ED, and then when they leave the emergency department. So we've had set up an external tent and triage process for when patients come in, they're actually within their own vehicle. They arrive to the front of the ED and they're directed into a tent area to obtain their information and kind of help stream where they need to be evaluated and what sort of evaluation they need in the department. If that's within a separate area of the ED, or other capabilities that we have, including being sent to the Respiratory Diagnostics Center, if it's just for a COVID test that they're there. If it's for a telehealth visit, which can actually occur while they're in the car, we'll evaluate them through that process. If they have respiratory complaints, to our separate respiratory area of the emergency department to evaluate them, or if they have other complaints, such as chest pain from what could be a heart attack or some sort of trauma, to our main area of the emergency department. So a physical separation that occurs there. And then we also separate patients and in that manner for their safety and also for our safety coming through. Each patient, as they arrive, is given a mask, a surgical mask that's brand new from our supply to help, again, protect both patients and our healthcare providers. And the hand hygiene is also encouraged as they come through the department. When our providers and our staff are facing our patients, we wear PPE, personal protective equipment, with every patient encounter with, at a minimum, mask and gloves. And in appropriate settings, gloves, face shield, mask, and a gown as well. We work to clean rooms between patients, and for those in our respiratory area, there's a specific protocol designed with our specialized infection preventionists to clean those rooms to minimize any sort of potential transmission that could occur. And then we also work to minimize the need for patients to touch surfaces as they're interacting with our staff and our providers. So, we've in taking and changing our processes, we've also in that system kind of role worked to closely share learnings across institutions. And so it's not just a top-down approach, working collaboratively to say, okay, here, this is working here, this is working at this other site. Let's share what we're learning and continue on from there. I'd just like to close by saying that we encourage seeking care for our patients if you need it, and encourage you not to postpone seeking care if you would have gone to the emergency department. We've prepared with appropriate safety and physical distancing measures to provide safe care for our patients. And with that, I'll turn it over to Dr. Lamb and then be available for questions.
Thanks, Avi. And Avi and I work together regularly on phone calls each week. So our system at Rex is going to be modeled very similarly because we have the same processes involved. I do feel very fortunate that we were not like New York City or other areas that were hit very hard, very fast. And we've really had months of planning for us to be ready for patients to come. So our processes have been fine-tuned for that. So starting, as we talked about, in the parking lot, to our triage process, to our waiting rooms, to our treatment areas, to our inpatient services, every area is segregated based upon as much distancing as possible, as well as making sure that patients that are more likely to be COVID are in one area versus another, and their treatment teams therefore are different. So most likely, if you're seeing somebody in a non-COVID area, and that physician and nurse are not going to be treating patients who are in our COVID area. So we're segregating as much as we can in that way. And we've also perfected techniques in terms of our PPE. We've been able to get plenty of supplies. We have special formulated wipes, hand sanitizer, soaps that allow us to be clean, as well as special sanitation in between rooms. And we've even made modifications within our rooms to make sure that we can use our UVC lights as well to try to keep things as clean as possible. And so, we mostly just feel fortunate that we've had that time because I know a lot of other places did not have that. And in terms of seeking care, I think of try to break things down as simple as possible. And I think of healthcare in terms of, 4 main stages, which are, preventative medicine. And these are all the preventative things that we're talking about, making sure that we're not spreading disease or illness to other people. And that's going to be the same for hoping for vaccines, eating well, exercising, which I think we're doing well currently as a community. The next stage is, that we manage is chronic care. So people need their diabetes managed, their hypertension managed, just to make sure that they're in the most optimal health for general life, as well as in case a COVID infection occurs. And then certainly Abby and I's big concern are acute care, as we work in the emergency department mostly. And what we're seeing is that people, because of their fear, they're not coming in to be seen. And we have a lot of processes to manage care in the acute setting within hours or less than a day of treatment. So when people present too late, we can't stop or reverse the process that's going to occur. And unfortunately, they're going to have permanent damage as a result of waiting too long. And then the final stage is supportive care, which is what we see in the hospital when we're managing care. And so we need all of these processes to be working effectively to make sure that we are being successful for our community's health.
Great, thank you so much. Now would like to take questions from the media, so please unmute yourself and go right ahead and ask any questions that you'd like. If you prefer, you can send us messages through the chat function of Zoom, but please just go right ahead and ask your questions.
I'm wondering, and this is for either doctor, are you concerned that we're going to see an increase in cancer because so many people maybe won't be getting screenings, colonoscopies, mammograms, things that, detect cancer early?
Yeah, I think just relative to what I was saying about making sure we're doing all stages of care, and if we're not doing preventative medicine, then we're going to miss that opportunity to stop and reverse a process, and then we're going to see a more significant, not necessarily escalation of cancer, but people presenting later where it's harder to treat or completely get rid of the cancer process.
Are people who come to your facilities telling you, hey, I tried not to come, this was a last resort because I didn't want to come to the hospital given what's going on, but I had to finally come? I mean, are you hearing that?
Yeah, I had one pretty significant case like that where I had, it was more of a family member that told me, but I had somebody come in respiratory distress and needed to be put on a respirator and go to the ICU. And this was not a COVID patient, just related to other chronic medical conditions. And after I called and spoke with the sister of the patient, they, she asked me, is it okay for him to be in the hospital and for us to treat him, being what was occurring? And it was such a dramatic kind of discussion that occurred with me that I was pretty shocked to hear that someone wouldn't think that we would take care of somebody who was critically ill just because of what's occurring with the pandemic. But that's the extreme note, but we're seeing it on almost all patients.
And just one more follow-up on that. I think one of the biggest concerns, and I don't know if you guys can address this, is when are hospitals going to allow visitors? Because some people, especially elderly people who are not presenting with COVID, they're afraid to go to the hospital because they don't want to be alone. They don't want to be isolated from their family.
So don't necessarily control the hospital policy, and we can get back to you around that. I can say that we've done everything that we can for helping patients connect in the use of that policy. So having telephonic devices available, encouraging patients to bring their phones or iPads. In our ICUs, we have distributed iPads so that patients can connect with their family members and have the ability to have that conversation. While it's a balance of keeping patients safe, keeping staff safe, and the visitors safe as well. I will say that it's a regular concern for patients coming through, and we're talking about it as when can those policies be updated, but I don't have any further information on that right now. Going back for a moment to your earlier question, yes, I think there's a danger in patients delaying seeking care, and had a patient who waited 2 days with chest pain at home before coming in, and they were having a heart attack during that period of time. And so, I think any reassurance that we can provide that we're going to do the best that we can from the standpoint of segregating out and screening patients to the best of our ability. And when we can't screen, treating as if there may potentially be COVID disease. So protecting patients, protecting those with them, and protecting our staff.
Thank you.
Uh-huh.
Have you seen an increase in other illnesses during this pandemic?
Have we seen an increase in other illnesses during this pandemic? That's, it's variable depending upon the epidemiology of what we're seeing. So as an example, we've seen a decrease in trauma because folks aren't out driving. And so a slight decrease in that. But as more and more folks, and we're starting to open up the economy and people are coming out, we're now seeing a slight uptick in trauma. So there's variability to answer that question.
And to say that our volumes in general are down, so we're not seeing as many patients as we were, I think mostly for fear of coming in. And so what we are seeing a lot less of is people presenting early enough for us to make a significant change in their health. And, waiting 2 days to come in for your heart attack could lead to permanent damage, where you come in within hours, you can go home the next day, essentially unaffected. So we're certainly seeing people present late, and therefore, in effect, it's different. We're seeing a lot more ruptured appendicitis than we would see just a regular appendicitis, for instance. So those are the kind of changes that we're seeing.
This is Richard Stradling at the News and Observer. Thanks for doing this. A month ago, the hospitals were describing this decline in non-COVID-19 patients at emergency rooms. And I think at the time, UNC across the system was saying that they were down 40 to 50% in the number of non-coronavirus traffic at the emergency rooms. Has that changed at all?
So Richard, I think that the numbers that we were quoting was 40 to 50% down overall volume. It wasn't just non-COVID related care. And so we're still at the Med Center and Hillsborough, somewhere between 30 to 35% overall down in volume. That varies, though. There are differences. This past Monday was significantly busier than that, 30 to 45%, 30-35% down. So, and a lot of that on Monday was non-COVID related care. So it varies.
Thank you.
Mm-hmm.
Additional media questions? So I wonder if you could address something as simple as, it's not that you've been in an auto accident. It's not that it's a cancer treatment, but something as simple as you have a chronic condition and you have a medication that you take. Say, for instance, you're taking blood thinners, and those need to be monitored pretty regularly depending on what kind you're taking. How important is that for people to be aware of and to make sure they address?
I think I'll go back to Ryan's structure and classification of the preventative care, the chronic conditions, the acute care. And so if you have a chronic condition that you're not resolving, that you're not taking care of, it's going to present in an acute exacerbation. And so, Phil, as you mentioned, our patients that have these chronic diseases like congestive heart failure, like COPD, that may be on a blood thinner that need to get that monitored. I think seeking care in an appropriate venue is absolutely important. So whether it's with us in the emergency department, if there's an acute exacerbation, or utilizing any other models of care that are available now that a fair number of different avenues are available, including telehealth, telephone encounters, video visits that are available for our patients throughout the system.
Dr. Lamb, Dr. Mehrotra, could you talk just a little bit about some of the lessons learned? We're obviously not through this pandemic, and they're talking about, as North Carolina reopens, we may start to see a surge of hospitalizations and people coming in through the emergency departments. What are some of the lessons learned over the past couple of months that are going to make things better for patients and for providers in the coming months?
I think that if we try to again break up the arms that we talked about, the preventative side, we've seen that in North Carolina and the community where people were affecting other people about 1 to 2.5. So for every person that got infected, they would infect another 2.5 people. We've been able to decrease that in our community to 1.1. So essentially, from our social distancing, from our protective measures, we're able to be safe. And so I think that that's a big part to help our staff know that we will be able to maintain our staff, and our staff can feel safe to take care of people, and people can feel safe to come and get seen. And then the community of, especially emergency medicine, has a very regular weekly updates where we discuss care around the country and around the world, what people are facing and what they're learning, and kind of cumulative looking at all the different literature to help us guide how we're going to approach a patient who has mild illness, moderate illness, severe illness. What are our treatment modalities? How are we going to use different techniques in the ER and the ICU to make people safe? And that care has changed pretty dramatically since March or February when we were initially talking about things compared to today. And that group of people continues every week to update us, as well as us communicating as a system twice a week to make sure we're all on the same page.
Yeah, Alan, I think that's a great question, because while we're dealing with this now, and initially we prepared for a surge, starting to learn very quickly that that's not necessarily a surge, and we're, instead of a sprint, we need to deal with a marathon. And then, actually transition from a marathon mindset to a triathlon mindset. So preparing for the longer term, taking the lessons that we have learned now and being able to apply them. What's this fall flu season going to look like? And being ready for caring for both COVID and non-COVID disease when we see the mixture of influenza come in there. So taking the lessons now, understanding what the PPE requirements are, and how we segregate patients to keep both patients and staff safe, and applying that going forward is absolutely something that we're looking to do and learning from as we're evolving, kind of, as Ryan said, across the region, state, and country. We're learning from our colleagues as to how care changes and what we know about this disease and how it impacts other diseases as well.
Any questions from the media? Please just ask your question and make sure you're take yourself off of mute first.
Sure. This is Richard Chatling again at the News and Observer. It seems like everyone who deals with the public, whether it's a retail store, a restaurant, or a barbershop, or churches, are trying to enact practices that will make people feel comfortable about coming back. And I guess I wanted to see if you could comment on the particular challenges for doctors and healthcare facilities.
The particular challenges in terms of patients coming back. I think that's the, from our standpoint, it is ensuring that our patients understand when they need to seek care, we're here for them. We're not just dealing with COVID disease. Emergency departments are a vital part of the healthcare system and provide both COVID care and non-COVID care, just as before. And we're doing our utmost in ways that we separate out that care and try and keep patients as safe as possible, utilizing that PPE kind of in a universal manner as we're approaching patients.
Richard, I'm not sure if you were asking too, what are the challenges for us to, make people feel safe or to do it, but a big part for us was making sure we had enough PPE. And I think in, February and March, we were very worried about that. But the system has done a great job making sure that we have plenty of PPE to give masks to patients, to have masks for their providers, to have all the things that we need to clean. Also, I think it's a little easier to show up with a mask and gown and be treated in the emergency room than it is, in the social setting of going to restaurants and things like that. So in some ways, it's a lot easier for us to be very well prepared than it is in the general public.
Thank you.
Real quick question. Has there been collaboration between hospitals and doctors, and how helpful has it been to talk to one another and try to implement something that maybe Duke has done or another national hospital or whatever? Has that happened, and has it been helpful?
Chad, great question. And so I'll say, I think in multiple senses, yes. As you've heard, we've worked closely across our system hospitals with UNC Health to learn from one another, take what's happening in one area, and what's happening in one area may be different than what's happening across. And so it's not always applicable, but we still learn from one another in those instances. We've also engaged with our colleagues in the local area to determine kind of what they're seeing, what their referral patterns are, what their hospitals that refer them are doing, and then nationally as well. Just this week we had a guest speaker in our departmental meeting from New York, and what their experience was, where they had a significant volume of patients arriving and how they dealt with that. Again, not all those lessons translate, but you can always learn in listening from those.
We've got about 2.5 minutes left on our Zoom meeting. If you've got any final questions, please ask those and we'll try to wrap it up. One final thing, if there's none from the media, one thing I was thinking about, and Amanda Lamb actually addressed it a little bit, are we seeing patients who are maybe already have a diagnosis, like for cancer, that are being hesitant to come in to get their treatments for cancer and other chronic illnesses?
Well, we're certainly seeing that in the emergency department, I think, as well as in the urgent care. And they usually mention that they do a poll of their friends and said, half my friends said don't go and half my friends said to go. So they're trying to take their time and learn whether they should or shouldn't go. So I think we're definitely seeing hesitancy. I think that the community physicians and oncologists in this case are doing a good job of reaching out and trying to be available and having virtual care so that they can be seen. But I still think that in general, we're seeing a significant decline in people seeking care in all specialties and in all areas of healthcare.
Great, thank you so much.
Can I ask one more question, Phil?
Sure. Go right ahead, we've only got 1.5 minutes or less.
Dr. Morocho, you talked about the marathon, the triathlon. In terms of your teams, your staff, how do you see them working with each other, talking to each other to try to encourage them to keep up the pace, to keep up the energy as this continues and as we look ahead to sort of an uncertain future.
Yeah, I think that we've seen a coming together of folks working together. It's been, when you're in a crisis mode, you have that, you're anticipating that surge, barriers drop down and people work together well. And then as we've tried to expand and in this anticipation of this process, that's only increased. And so we've got a close working relationship, ensuring that we're looking out for one another, both our physical safety with PPE availability and advocating for that, but also psychological safety and mental health, and encouraging each other to take breaks, ensuring that we're looking out for one another, because this is a long-term scenario. And so checking in on one another, absolutely.
Great. Well, thank you. We've run out of time on our Zoom meeting, so thanks everyone for joining us. We will have the